Summer, for joining us today. You're the CEO of Maternal Mental Health NOW, and I'm really excited to talk with you today about what you're doing in this space. Thanks
Thanks
for
for having
joining
me.
us. Yeah, this is such an important topic, and I don't think that the public in general really realizes how crucial and important it is. Um, And we're going to cover that. Like, what does it mean to you? What does it mean to your organization? What is the work you're doing in with providers, education, laws, all of that we're going to cover. So, thank you for sharing all of that with us.
You got it. I'm glad to be here.
Yeah. So the first question is how did maternal mental health now get started? What is the origin story?
Sure. Maternal Mental Health Now was founded in 2007 by Kimberly Wong, who experienced severe postpartum depression after the birth of her daughter. She reached out to her OB-GYN for help and she said, something's seriously wrong. I need help. And her concerns were dismissed. Her doctor told her she's a type A personality, get some rest, relax, you'll be fine. And she wasn't. She was hospitalized twice for suicidality. And the care she received in the psych ward was subpar at best. She was separated from her baby at that time, and she had a really long road to recovery. But ultimately, she did recover, and she thought to herself, if I had so much trouble finding help, and I am well educated, have good health insurance, I have a supportive partner and family, I speak English, like I have a car that to drive to therapy appointments, what would I have done without any one of those
Hmm.
resources? So she started cold calling people that she knew, members of her care team, friends, friends of friends, people at the county of public, at the county, including the Department of Public Health and Mental Health. And she convened these meetings of volunteers of people who wanted to do something about this issue. She made empanadas, homemade,
Hmm.
to entice people to come to a meeting. And that's how Maternal Mental Health Now was started. We were called the LA County Perinatal Mental Health Task Force at the time. And these volunteers sat around a table and said, what's the number one issue? What's the number one barrier to care? And they decided it was lack of informed providers.
Oh, wow.
So, like doctors, nurses, even mental health clinicians, they go to school, they learn all about everything else, but they're not trained about, well, the medical professionals are not trained about mental health issues. And even the mental health professionals aren't trained about the specific time period of having a baby. So they decided we want to train people, anyone who comes into interaction with a pregnant or postpartum person. And they developed a training curriculum. They started knocking on doors, said, please let us come in and train your staff.
Wow.
And now, 18 years later, we are still doing that on a pretty significant scale.
So almost 20 years,
Yeah,
and starting off with just, I see this problem, I've experienced it, now I'm knocking on doors and trying to find a solution and providing answers.
right,
That's pretty amazing.
right.
Yeah. So how did you get started with this organization? Why does it matter to you that you've been with it for 10 years now?
15 years.
15 years
Yeah.
now. Yeah.
For me, it was luck. I had recently moved to LA. I was pregnant, or I'd actually just given birth to my firstborn child. Um, and I had a part-time, like freelancing position that I was working from home. And I was looking for additional work. And I found a job ad on Craigslist and I applied. It was for a part-time development manager. And that was very much my skill set. And it was work from home and it was part-time. So it really suited the phase of life I was in. And it was for the LA County Perinatal Mental Task Force. And I looked at their website and I thought, wow, they're doing a lot of stuff. And there's a lot of really smart, committed women involved in this
Mhm.
organization. This looks great. But I was like, but they need a new website. And I was like, I said to myself, I can help with that. So anyway, I applied and I got the job. And it's turned out to be a big blessing in my life because I've gone on, I've had two more children. I've suffered mild postpartum depression through my own experience. When I was pregnant with my second, my sister gave birth to a baby who passed away 6 hours after birth.
Oh my goodness.
And that was really challenging for her and our whole family. It was challenging for me. Um, I went through a divorce where paternal postpartum depression was likely a factor. And then I have friends and family members who have gone on and had babies and had some mental health struggles. So throughout that whole experience, I had a community that I could turn to for information and support and compassion. And I want that for all of LA County's birthing people. Like, we all deserve
Mhm.
that
Mhm.
community of support in our childbearing years.
Yeah, so you felt supported through. That's awesome because I don't normally hear that.
Before I applied, I didn't know what perinatal mental health was,
Yeah.
right? And a lot of the people that are involved in the organization are therapists that have their own experiences with
Mhm.
perinatal mental health challenges. And they didn't know what it was, even though they'd been in school for mental health care.
Mhm.
So a lot of people come to this work through their personal experience and um, wanting to make things better.
Mhm. Yeah, and I've also I have 2 kids myself and also faced challenges and experienced the difference between having support in an office
Mm,
and not having support, right? So people that are afraid of the issues versus people that say, "I got this, I can take care of this," or
mhm.
connect you with the proper resources. What would you say is the biggest misconceptions that are out there in regards to perinatal mental health?
Well, first, I think people don't understand that the clinical term for it is perinatal mood and anxiety disorders.
Okay,
So it encompasses a range of diagnoses that can
that's a
take
lot.
place during pregnancy and also postpartum. It covers depression as well as anxiety. Um, the colloquial word is postpartum depression. That's what most people know, but that's a bit of a misnomer because that only covers postpartum and
Yeah.
depression, right? But in actuality, it can be anxiety, it can be rage and anger. Um, it can be, you don't always cry, right? Or are sad. You can be highly anxious. You might put the baby to sleep and then you can't sleep because your mind is racing about what could happen to the baby. It could be intrusive thoughts. It could be, I don't want to drive because I'm scared about like that I'll crash and hurt the baby. It can show up in many different ways, shapes, and forms. And then the other misconception is how common it is.
Hmm.
Nationally, the statistic is 1 in 5 birthing people will
Oh,
suffer from
wow.
postpartum
It's a
depression,
lot.
but we know it's more.
Oh,
In communities of color and other marginalized communities, it's 1 in 3.
oh my
And
goodness.
I heard today that there is a statewide survey where that has the statistics to support the 1 in 3 number.
Hmm. Why do you think there's so much stigma or misconceptions around this topic?
I think having a baby is supposed to be the most joyful, wonderful time of your life. You have magazine covers, you have social media influencers, like their looks great, their makeup's done, they have a newborn in their arms, and they look peaceful and joyful.
Hmm. Hmm.
I think there's a lot of media images about what it's supposed to look like, and fewer people talk about what it's really like.
Hmm.
So people feel a lot of shame and embarrassment about speaking up about their symptoms and reaching out for help. I also think in the provider community, providers are unprepared to address the issue. A lot of providers they want to screen, they want to help people, but they have a fear that if they screen and encounter a patient who's really struggling, they don't know what to do with them. They don't know where to refer them to. And that lack of mental health resources that are accessible to the average person are few and far between. You can find a therapist that specializes in perinatal mental health and charges $200+ an hour. That's fine. But if you're a Medi-Cal member, finding a therapist at all, not, nevertheless, one that specializes in perinatal mental health can take weeks.
Hmm.
They may not even ask you about your where you are in your perinatal journey and upon intake. Um, and so there's a real shortage of informed mental health clinicians
Yeah.
serving the medical community.
Yeah, for sure. And that's what we hope that the program here can help with
Yeah,
is because education can be that key. But before we jump into education, you know, what happens? What are the consequences of not getting the care?
yeah, that's a great question. Um, Untreated perinatal mood and anxiety disorders have impact on the fetus when you're pregnant. You're more likely to give birth to a low birth weight baby. You're more likely to give birth early, resulting in a NICU stay. It has an impact on the bonding and attachment that's supposed to have between the primary caregiver and the infant in the first months and years of life. Untreated postpartum depression results in higher levels of marital stress and divorce. Mathematica did a study that found that untreated perinatal mood and anxiety disorders in California cost the state $2.4 billion per year.
Whoa.
And that's measured through medical costs, lost productivity of the parent in terms of not going back to work, and the impact of the lack of bonding or attachment or the medical costs that having a low birth weight baby or an early a premature baby will have.
Wow. Yeah. And then do you see a long-term effect too, besides, these documented pieces, but just family relationships and how we raise children? How does having a mother who's not okay affect a child
Yeah,
throughout their life,
there's studies
or a
that
father?
indicate right that they'll untreated perinatal depression during the first couple of years of life can later on result in difficulties in school, behavioral problems. It's all about that bonding and attachment that happens. If a young child needs to know that someone is there to respond to their needs, right? Whether they're hungry or tired, right? They want to know that someone will respond to them. And if that doesn't happen, it can result in negative outcomes later on.
Yeah. Yeah. So what do you think is at the core of the problem with perinatal uh,
Yeah.
untreated
I mean, I
perinatal
think
conditions?
I think the world is not built to support new families.
It is not.
And it's such a what I really enjoy about this work is that it's the consequences of doing it right are huge, right? It's such a preventative measure
Hmm.
to address the perinatal mental health of the parent, because when you're pregnant and when you're postpartum, you are visiting the medical office at a much higher frequency than any other time in your life, right? You have your pregnancy appointments, your prenatal appointments, as
Yeah.
well as your well child visits, not to mention your sick child visits,
Yeah.
right? So there are so many opportunities for the healthcare system to identify and respond to the issue. And if they do and they do it right, um, we can prevent a lot of problems down the road. But uh, one issue is that doctors and nurses are very motivated by the insurance companies to bill. So they don't have a lot of time to spend with their patients, even though they want to, right? I don't think anyone goes to med school not wanting to help people. They want to help people. But once they're practicing, there's these other realities at play. So that's one issue or one like core issue. The other issue is that a lot of patients don't want to speak up because of the shame and the
Mm.
embarrassment. Particularly in marginalized communities, there's fear that if you speak up, there might be involvement of CPS, Child Protective Services, and so they don't want to speak up out of fear.
Or maybe being hospitalized
Right.
too, like, because there's all this, the talk about the postpartum psychosis,
Hmm.
right? And like, then you're going to get your baby taken away. So,
Which causes much more trauma.
yeah,
It
if you
compounds it.
if you can keep them together.
Right.
But there's all this middle ground area that's not being addressed that's really valuable.
There's a lot of opportunities for de-escalation, if you will. If
I
you're
like
able,
that. DS, that's a
yeah,
great word.
if you're able to address the symptoms in the parent by getting them resources, we can keep families together.
Yeah, yeah. So tell me about the work you've done um, to provide that education for providers. What are they learning? What are the top things that they need to know?
Mhm.
And then how the legislation piece
Sure.
kind of fits into all of that.
Sure. So our training department has created thousands of curriculums at this point that are targeted to a lot of different audiences. We've trained OB-GYNs on different medications that are appropriate to use to prescribe during pregnancy or postpartum. And we've trained children's librarians about what the issue is, what it might look like in terms of signs and symptoms, and how you start a conversation
Hmm.
with a parent about it, and everyone in between. And those trainings are delivered in person. They're now delivered on Zoom, as well as we have an online training program. So it's pre recorded and self paced. People can take that. We also offer consultation groups because we know that we can train a group of people and they leave the 1 day training with a higher level of knowledge and information about the topic, but that doesn't necessarily result in practice change. They probably go back to work and kind of fall into the
Hmm.
same patterns that they, or ways of working as they did before the training. So our consultation group is an opportunity for providers to come and speak to each other, as well as our director of training, who's a licensed clinician, and get feedback on cases that they've seen in the past month
Oh, that's valuable.
and
Yeah.
think, hey, did I do this right? What did I not think about? What would you have done? And they're
Mhm.
able to process and reflect on the experience and hear the experiences of others so that they're better prepared to
Wow.
change the way they practice moving forward. Um, we are working with a program called the Los Angeles Maternal Mental Health Access Program, which is working with a handful of community clinics in LA County to integrate perinatal mental health care into the primary care setting, meaning the obstetric setting as well as the pediatric setting. And something we've learned there is that, yeah, change is hard and it's slow.
Mm.
Um, we've also trained home visitors in LA County for a number of years.
Oh,
And so the home visitors are really well positioned
yeah.
to address perinatal mental health because they establish a long term relationship with the client. And so I have some numbers or some statistics around what screening looks like in the home visiting setting versus in the clinical setting.
Oh my
Um,
goodness, this was interesting.
According to the Los Angeles Home Visitation Consortium, they have screened 98% of the families they served for perinatal mood and anxiety disorders 2 years ago. And that is compared to this group of clinics we're working with in Llama Project. They screened only 5%.
Oh, wow.
And then in terms of the positive screening rates, according to LA County Home Visitation Consortium, out of all the patients that they served in 2024, they screened 98% of their patients for perinatal anxiety and depression, whereas the community clinics that we're working with in the Llama Project screened 53% of their patients. So screening rates are higher in the home visiting setting. And then in terms of the screening results, the home visitors saw 20% of their patients screen positive, whereas the community clinics saw only 5% screen positive. So I think in addition to screening, like needing to take place, we need to address how the screening is conducted.
Absolutely. Yeah.
And I think home visitors are doing a better job of that because they're establishing a long term relationship with the client over time and they're in their home and it's less of a system, right?
Mhm.
Uh,
Feels less clinical.
it's less clinical. The patient or the new mother feels more comfortable disclosing symptoms.
Yeah. So when you said a positive rate,
Yeah.
that means they've disclosed symptoms.
Yes.
So I'm surprised that only 5% in the clinics were surveying to begin with or screening to begin with.
53% were screened in the clinic,
Okay.
but only 5% screened positive, meaning
Right.
they disclosed symptoms.
Yeah.
And we know, particularly in community clinics, they're serving under resourced communities. So we know that the prevalence rates are much higher than 5%.
Okay. So whose responsibility is it then to help people disclose what they're really going through?
Yeah, I think it's a multi-layered solution. I think the responsibility is the provider, but really anyone can screen. Like again, the children's librarian can screen, a friend can screen, a family member, a grandmother can screen. I think the screening tools are evidence-based. There's two that are most common, maybe three. In fact, the PHQ-9 is one of them, the Edinburgh-3 is another, and then you have the GAD-7 as well. So every medical center chooses which tool that they want to use. So it may look different, depending on where you go, but it's a survey.
Mhm.
And sometimes these screening tools are administered with a pen and paper. Sometimes it's online, and sometimes it's administered verbally. But at the end of the day, I think we can really simplify it and just say, like, how are you feeling? How are you doing? Yeah,
Mhm. Yeah, and then how can you build that rapport and that environment that people will feel comfortable really disclosing what they're
right,
going through?
right. I brought my daughter in for a well baby checkup at 2 weeks, and she had dropped over 10% less than her birth weight. And that's bad. That's
Mhm.
bad. And I felt like a big kick in the gut at
Mhm.
that doctor's appointment. And I think I started tearing up, and the pediatrician, paused and looked at me and said, "How are you doing?"
Yeah.
And that's when I cried more because I felt like a failure because I was trying to breastfeed, and that wasn't
Yeah.
working,
Yeah.
right? So she's the one that prompted me to look for support, and she's the pediatrician. She wasn't even my doctor.
Interesting. Yeah. Because of all those well baby checks.
Right.
Yeah. That makes a lot of sense. So what advice would you give to providers who may be watching this?
Um, I would say, like, pediatricians particularly, but also OB-GYNs are really well positioned to address perinatal mood and anxiety disorders amongst their patient population. So take the time, get to know your patient, ask them how they're doing, and when they respond that they need support, have a list of resources or ideas available to them.
Yeah, put that together. Yeah. And then can you tell me about the current laws that are in
Sure.
place to support?
So in 2020, Maternal Mental Health NOW was involved in co-sponsoring two bills that passed and became law. The first one is AB 2193, which requires all OB-GYNs to screen or confirm that screening has taken place at least once during pregnancy and once in the postpartum period. And the other one was AB 3032, which requires all birthing hospitals in the state of California to provide education on perinatal mental health to their patients, but also their providers.
Whoa.
And yeah, the passage of both laws was a big success. And at the same time, what was not included in the legislation was a monitoring and accountability piece. So that's why SB 626 was introduced last year, and it was 2 years, meaning it's still under consideration now. And SB 626 takes 2193 further. It requires all OB-GYNs to screen and provide treatment. It requires health insurance companies to cover that treatment, and it requires healthcare companies to ensure that that screening is happening. So there is an accountability measure built into SB 626.
Wow. So when will we know if that passes?
You should know in June.
Oh, coming right up. Yeah. So can people support
Yeah,
this getting passed? How could
yeah.
they do that?
SB 626 is being sponsored by the California Perinatal Wellness Alliance. So if you Google that organization, they will have a way for you to show your support for the bill.
Okay. So yeah, that happens a lot where laws are passed,
Yeah,
but then you need another law to like make
I
sure it's
know.
implemented the right way. And how many people are actually doing this right now? I mean, there is a law that says now that you have to provide that education, but it's not really happening, right? From where you're sitting, what are you seeing?
After the passage of 3032, I what we did see was actually Maternal Mental Health Now was involved in a project with the Hospital Quality Initiative to build a learning community consisting of staff members at all the birthing hospitals across the state to receive that education. And as part of this project, we provided it was during COVID time, right? So we provided webinars and online trainings on how to screen in the hospital setting. Um, Part of our messaging in that was that screening in itself, like when done correctly, is a form of care. It's a form of
Oh,
intervention. Yeah,
interesting.
so because when you conduct a screen in a caring and compassionate and trusted way, you're opening up a conversation. And if the patient has been struggling but burying their feelings, like just allowing them to speak about their feelings is often a release and they feel
Mhm.
better,
Mhm.
right? So you've just opened the door to the conversation by conducting a screening.
Wow.
So, yeah, this learning community provided a lot of training to the hospital staff across the state. We also provided templates for brochures and a patient engagement tool, which addressed the patient education piece of the bill. So those materials are still available on the HQI website.
Okay. So they're available. We can put links to all of this
Yeah.
stuff for
Yeah.
providers and things like that. Um, so yeah, what is the world you want to see in terms of this issue? Like,
Yeah.
paint me a picture of what it would look like for a birthing person.
Um, I think a birthing person, when before they even get pregnant, they're
Mm,
aware that
take
this
it
is an
way.
issue.
Yeah, we're talking before pregnancy,
Before
even. Yeah.
pregnancy, some people who have mental health challenges prior to pregnancy, they're at higher risk.
Hmm.
So they should know going into pregnancy that they are higher risk, and these are the signs and symptoms to look for, and this is who they're going to call should those symptoms present themselves. Particularly people who are on medication or if they're on SSRIs when they get pregnant. A lot of OB-GYNs advise the patient to get off that medication right away once they learn that they're pregnant, and that's dangerous.
Mm,
That most cases of postpartum psychosis will result from that sort of course of treatment. There is obviously, I'm not a doctor and I don't want to speak for them, but there are risks and rewards like to consider in each patient's case. So a lot of OBGYNs or reproductive psychiatrists will advise that they titrate over time. Or they stay on the medication at a lower dose during pregnancy, or they stay on at the dose they were on before. Anyway, all that to say, there's a lot of misinformation about medication and pregnancy and lactation. And there are a handful of reproductive psychiatrists in California that are very well educated on how to manage those cases. In fact, I just thought of another resource. It's available in LA County for medical doctors who are prescribers, and if they're treating a pregnant or postpartum person and they're not sure how to manage their medication, they can call a phone number. It's called the Promise
oh,
line,
I never heard of that.
and they can speak to reproductive psychiatrists in real time who will give them advice on how to manage that medication for that patient.
Hmm.
So that is actually one of about 20 something programs across the country, which were created because there's such a shortage of reproductive
Yeah.
psychiatrists. But there's a lot of prescribers, and a lot of prescribers were prescribing or giving their patients poor advice during pregnancy and postpartum. So this program was created to address that.
Wow. That's great. So, because it feels like, at least when I was pregnant, it felt like a lot of this is so mysterious.
Hmm.
Like, what really is bad to take in pregnancy or good to take, when it comes to medications or even the foods you eat.
Right,
It just seems like there's so many unknowns,
right,
which contributes to the anxiety, actually.
right, right,
But knowing that there are resources and we can link them that providers can be aware of and provide to people. Um, but you're also saying that like the education and the providers are what you see as the kind of the one of the biggest solutions to this problem.
I do. I think right, education for the patients, but not in a doom and gloom and
Yeah.
way. We want to keep it uplifting, but just matter of fact, like this is common. There is help available. Know your risk factors, right? We need to build up the referral resources because again,
Yes.
providers, that's still a very, very key issue or key challenge is that even if a provider knows where to refer a patient, there may still be a 6 week or longer wait time. So,
Which.
to that end, Maternal Mental Health Now has a peer support program for pregnant and postpartum people, which can be a stopgap measure, like to help the patient during that 6 week wait time while they're waiting to get into therapy. It can also serve as a long term measure because who doesn't need a friend who's been through a similar experience and someone to talk to?
Mhm.
So, that is also a solution,
Mhm.
right? Particularly for mild to moderate cases.
Yeah. And then does your work also include, you know, infant loss and miscarriage and all of those things that occur?
Yeah. Yeah, we just did a event at UCLA Anderson Business School featuring a fertility coach who was a very ambitious and high achieving woman who went to business school and then pursued a career. And then when she was 36 and decided she was ready to have children, had a lot of trouble. and she talked about the impact of that on our mental health, right?
Mhm.
So yes, this topic area covers trying to conceive, infertility, miscarriage, and infant loss. It covers adoption, like people who adopt can suffer from postpartum depression. Fathers can suffer from paternal postpartum depression. Um, and there's a lot of talk about menopause and the
Oh, wow.
depression that happens at that stage of life, too.
And are you working on that
No,
too?
no, that's outside of our scope.
Yeah.
But the laugh, a lot of the volunteers that were involved in the founding of Maternal Mental Health Now are now in that stage of life, and they're
Yeah.
like, it doesn't go away.
Yeah. So it's like every stage of the reproductive
Cycle. Yeah,
cycle has its own challenges and
right.
mental health needs and whatnot. You've been at this for 15 years. How have you seen the landscape change?
It's changed a lot in 15 years. In 2010 or 2011, when I started working there, I can only think of Maternal Mental Health Now and Postpartum Support International as the two organizations that were working on this issue in the US. And now there's more than I can count.
Mm,
Um, Postpartum Support International works nationally and even internationally, and they are a great resource for provider education. They operate the National Maternal Mental Health Hotline that's funded by HRSA at the federal level. And they have a lot of online support groups. But I think there's a real need for local organizations to be addressing this issue in their communities, which is what Maternal Mental Health Now is. And there's a lot of similar organizations to Maternal Mental Health Now across the country.
that's great.
Yeah.
Yeah.
There's also in California, there's a big emphasis on doulas right now because
Hmm.
doulas are very well positioned to
Mm,
identify and mitigate depression or anxiety during pregnancy or postpartum too. So that's another solution that or another form of work that's building a lot of momentum at the moment.
yeah, wonderful. And can you share a success story with us? Something that you can think back of in your career and say that you're really proud of or gives you hope?
Um, about a month ago, we hosted our third storyectomy baby bumps event, and this is a partnership we do with an organization and a comedy club in Santa Monica called The Crow. And the founder of The Crow, her name is Nicole Blaine, and I've known her for 15 years. She had her own experience with postpartum depression and anxiety. She's spoken at some of Maternal Mental Health Now's conferences and shared her story. But she's an incredible storyteller and she's an incredible facilitator. So, what she does for this program is she recruits people with lived experience with depression and anxiety or other hardship during pregnancy and postpartum. They meet for a period of 6 weeks, once a week, and she teaches them how to tell their stories.
Oh,
And then that culminates in an event at the comedy club where they take the stage and they tell their story. And many times they find the humor in their story and the audience is laughing, but they don't force it because some of the stories are really tragic. And people are also crying in the audience. It's my favorite event that Maternal
wow.
Mental Health Now is involved in. And it's so powerful because not only to those in the audience, like, watching someone be vulnerable on stage about a very, very vulnerable time in their life or vulnerable experience is incredibly moving. But it's also fun to laugh about it and find the humor in it. But what I'm told is that those who participate in the storytelling workshops find a level of healing by connecting with each other and that shared experience that is more impactful than years of therapy.
That's amazing.
So I think it's really important for people just to talk about their hardships
Yeah.
and share that with others.
Yeah, that makes a whole lot of sense because yeah, you can feel very alone
Yeah,
with a baby by yourself taking care of yes, so and I of course believe in the power of storytelling
of course,
for
right.
sure. How can people support the work that you're doing at
Um,
Maternal Mental Health Now?
well, we can go to maternalmentalhealthnow.org and donate. There's also an area of our website where you can share your own story. You can send an
Oh,
email. If you sign up to our newsletter, you'll be informed of future storytelling opportunities. Um, we have We just launched our webinar series for 2026. We're looking at the intersection of perinatal mental health and disability. So these
Oh,
are free. You can register
wow.
for a webinar and learn more information. And we have our annual conference coming up in October. So
Wow.
that's geared for providers, mental health clinicians specifically. But this year we'll be looking at both evidence based practices for treating perinatal depression as well as community based practices and the juxtaposition of the two.
Wow, you all are doing so much.
Yeah.
Fantastic work. Thank you so much for coming and sharing the work you're doing and all of the findings and how people can be a part of just creating a better world for parents and kids.
Thanks so much.